Okay, so we're going to talk a little bit about pulmonary edema, fluid in the airways. This gives you an example of what you have. You notice if there's fluid in the airways, it's going to be kind of hard to breathe because now you have a major diffusion defect, and the capillary bed is much further away from that alveoli. So basically, what is pulmonary edema? A lot of fluid collecting where it's not supposed to, okay? What happens, as you can see with this, there's going to be some swelling that goes on with it. Your surface tension is going to increase because if you remember back in pulmonary A&P, we talk about surface tension and the fact that the alveoli want to collapse because they have the tension, but we have a thing called surfactant. Well, it's not going to work extremely well when you have pulmonary edema. So there's a greater tendency to want to go ahead and shrink that cell, that alveoli, so that you can increase, because of the increase of the surface tension. And this is going to lead to atelectasis at that particular point. It's also going to affect your lymphatic flow and the return of the lymphatic fluid. So what are we going to see? Some interstitial edema, alveolar flooding, that increased surface tension that's going to cause the atelectasis at that point. You're also going to see frothy white or pink secretions. Pink secretions happens when the fluid is mixing with the capillary blood. And when you see this, it's not, oh, could that be? It's quite evident that's what it is because it's a lot of fluid coming out of the patient at that particular point. There's two of them that we talk about with pulmonary edema. One is cardiogenic, the other is non-cardiogenic. They've just renamed them hydrostatic and non-hydrostatic. So that's something that's coming down the pike. Most common cause of left-sided heart failure is you're going to see that with your cardiogenic pulmonary edema. And what's going to happen is your left ventricle is not working like it needs to. And we see that with congestive heart failure. So what's happening at this point is that the blood is backing up, because if the blood can't get pushed out of the heart, there's not too many places it can go, so it has to back up in the system, and it's by backing up into the system and changing the pressure gradients in the lungs that we start to see our pulmonary edema. And there you see your hydrostatic pressure is about 10 to 15 millimeters of mercury, and that pushes the fluid out of the pulmonary capillaries into the interstitial space. Within the vascular system itself, you have otic or osmotic pressure caused by the protein albumin, and it's designed to keep the fluid where the fluid's supposed to be at that point. And when you start to lose that at that particular point, now the fluid can go ahead and start to leak out, and then we're going to see some edema at that point. So what are some of the causes of these? And if you notice, most of these are all cardiac related, okay? And who's at risk for these? Male, female, family history of coronary heart disease. If you're a smoker, if you're obese, how many of you ever thought that your LDL or bad cholesterol, high or then low HDL, which is your good cholesterol, could even cause something like this? So lots of things that we can see that are going to cause problems for us. Cardiogenic pulmonary edema, this is a result of not the heart. This is a result of something else that's happening. And we can see ARDS is part of this. Pulmonary infection is another one. The one I always found very interesting are acute head injuries. And that has to do sometimes with the fluid backing up simply because of that. Other causes that we see is severe airway obstructions. People who are drowning will see this problem with it also. Drug overdoses, both legal and illegal drugs, are also part of this too. And some other ones too, as you can see here, chronic alcohol ingestion, aspiration is another one. Pulmonary embolisms are really kind of interesting. We're going to talk about those next. And then you can have some people who decide to go to Denver and hike the mountains the first day they get there. If they're not acclimated to it, then they're going to end up with cardiogenic pulmonary edema. So what do we see with these? Atelectasis, a lot of secretions, an increase in that AC membrane, less efficient gas exchange also. And remember, if you're going to be hypoxemic, you're going to have an increased respiratory rate, but secondary to your tachycardia, which is an increased heart rate, okay? Your blood pressure is also going to go up. This is where we talk about Cheyne-Stokes. We haven't talked about that. And remember, Cheyne-Stokes is sometimes called accelerating, decelerating. It's a regular pattern of breathing that you start very slow and then you go up, and then your breathing starts to come down again, and then you go into an apneic period and it repeats itself. One of the things we're going to talk about as we go through some of the other diseases and processes that happen to folks, Cheyne-Stokes is not a good form of respiration. You can have some orthopnea. Remember, with orthopnea, you can't lay down because you can't breathe. You will be cyanotic. There's your cough and sputum, nice and frothy at that particular point. Increased tactile vocal fremitus. Remember, you have lots of atelectasis going on at this particular point. And increased atelectasis, increased consolidation is going to give you an increase in your tactile and vocal fremitus. And because you have fluid in the airways, we're going to have that crackling and that wheezing because those airways are popping open. With pulmonary edema, when you're listening to your patient, assessing your patient, you have to listen through that entire respiratory cycle, because at the end of inhalation, when you're listening, a lot of times is when you're going to hear those very fine crackles that tell us this patient has some fluid in the airways. Your PFTs, very telling of restrictive disorders that we normally see. You can see they get a little bit worse as you get worse. Arterial blood gases, basically the same that we see with our restrictive folks. Some of your lab procedures, low potassium, low sodium, low chloride. Why is the question people ask? Well, first of all, you got to think about it, that you're flooding the system. You have all this excess fluid. And when you have fluid, what has to happen? It's going to go ahead and flood out those electrolytes. One of the things you have to be careful of when you're working with patients who have this is that we're not going to give them any more electrolytes, because once we remove the fluid, then they're going to have too many electrolytes in their body, okay? And then BNP is something we'll talk about. It's elevated in heart failure. That's all you need to know at this point. Your chest radiograph, bilateral fluffy opacities, fluid, okay? And you can see the dilated arteries, the curly A and B lines, and then sometimes you'll see these bat wing or butterfly pattern. Really kind of neat if you go and take a look at those. And then sometimes you can also see a pleural effusion. And so now you have the whiting out of the area in the pleural space that could be pushing up on the lungs. And now you also have those bat wing patterns with it too. Okay. And with cardiogenic pulmonary edema, if it's only mild left-hearted failure, we're just going to see some pulmonary venous congestion with dilated pulmonary arteries. And that's looks like sometimes your curly A and B lines. So there you see with this one, with moderate, there's your A and B lines. The heart has expanded. It's more than half of the diameter of the thorax in your PA chest radiograph. Remember, that's something you also see with patients with COPD. And that's how you can tell that there's cardiomegaly of some sort going on, okay? Severe left heart failure, cardiomegaly, we just talked about that, pulmonary artery engorgement, interstitial pulmonary edema. There's those bat wings again, and again, you may see those pleural effusions. Non-cardiogenic pulmonary edema, nice fluffy densities also, much closer to the hyaline. The infiltrates can be unilateral or bilateral, especially if you have something that's aspiration. Aspiration, for the most part, can be very unilateral, doesn't necessarily have to be bilateral. Perfect example of this, if you're laying down and you're laying on your side and somebody's throwing grapes into your mouth and the grape goes in, but instead of going in your stomach, you now aspirate it, it's going to go to the lower portions of the lung on the side that you're laying, and that's going to give you a unilateral infiltrates at that particular point. And there you see it too. The pleural effusion is not normally present, and sometimes that cardiac silhouette is normal. So how do we treat pulmonary edema? What caused it? We got to figure out what's going on with it. We're going to give you diuretics. We're going to give you some other drugs. We need to see what is happening with it. Okay. And so, as you can see with non-cardiogenic, we're going to use supportive, ensuring adequate ventilation and oxygenation. Sometimes we can use CPAP or BiPAP with this. CPAP, BiPAP puts more pressure into the airways, and when it does, it's going to be able to force that fluid out, and those patients can be much more comfortable because they can out-breathe. Cardiogenic pulmonary edema, then we have to look at reduction of the pulmonary venous return, reduce that preload reduction, reduce the afterload. Remember, preload is basically how much stretch you're going to have. Afterload is what you're pushing against. And we're going to give you some inotropic support. We're going to make your heart beat much better. And if we can get that heart beating much better, then we can go ahead and take care of or pulmonary edema. And then there's different drugs that we can also give. Again, we can give you the diuretics to help remove some of the excess fluid. Other things are going to be your oxygen therapy protocol, lung expansion, and in some cases, mechanical ventilation is needed, especially if it's really severe and we're trying to work on it at that particular point.